Hello, I'm Dr. Laura. In today's video, we're going to shed light on a critical health issue: how to use aspirin safely to prevent a heart attack and unclog arteries. This tiny pill is truly a silent lifesaver, having saved tens of thousands of lives each year. Its power comes from its remarkable ability to prevent the formation of blood clots, the main culprits that block blood flow to the heart and lead to a myocardial infarction. However, a wave of confusion has emerged in recent years as many people have suddenly stopped using it. So what is the underlying reason for this change? Isn't aspirin an over-the-counter and relatively safe medication? This is the crucial point. In 2022, the U.S. Preventive Services Task Force, USPSTF, changed its recommendation, stating that not everyone should take a daily aspirin to prevent a heart attack. This change, while scientifically based, immediately caused a storm of misunderstanding in the community. So, if an over-the-counter medication that is easy to purchase has the ability to save so many lives, what is really going on? Why this sudden change in this video? Our goal is to clear away that cloud of misunderstanding. We will discuss in detail how to use aspirin strategically to clear your arteries and prevent a heart attack and stroke. We will also delve into recognizing the signs of a heart attack, because understanding the symptoms of a heart attack is the first and most important step in protecting yourself and your loved ones. And just as importantly, a crucial part of this video is when you should absolutely not use aspirin. We will explore alternatives, including other prescription medicines for heart attack, as well as natural supplement options. One of the most dangerous situations we will analyze in depth is atrial fibrillation. This is one of the causes of heart attack and especially stroke, against which aspirin is nearly powerless. We will learn why this difference between a heart attack versus stroke is so important in this story. Finally, we will shed light on the LP, a factor, a genetic wrinkle in the overall picture of cardiovascular risk that many people are completely unaware of. Let's find out together. My name is Laura, and I am a doctor specializing in preventive medicine. I began my career as an ER doctor, and what troubled me was witnessing so many patients suffer from events that could have and should have been prevented. That is what motivated me to dedicate my career to the field of prevention for the past 30 years. To truly master this knowledge, we need to understand three basic foundations regarding aspirin. First, what exactly is aspirin? Its history is not an accidental discovery in a lab. In 1897, a chemist named Felix Hoffmann, working for the Bayer Company, successfully refined and commercialized the compound that would later become the aspirin pill we know today. But its origins date back 4,000 years, when the ancient Sumerians discovered that boiling willow bark could help relieve pain and reduce fever. The salicylate compound in that willow bark was the precursor to acetyl salicylic acid, the chemical name for aspirin. Second, and this is the most important part, how does aspirin work to prevent a heart attack? It has two main effects. The first effect, as the Sumerians knew, is pain relief. But the effect we are interested in today is its anti-clotting ability. Aspirin works by intervening with platelets, the tiny blood cells that initiate the clotting process. It makes the platelets less sticky, preventing them from aggregating together. Imagine this when an atherosclerotic plaque inside an artery ruptures the body, reacts as if it's a wound, and dispatches platelets to patch it up. But this massive aggregation forms a large clot, completely blocking blood flow. That is the cause of a heart attack. By disabling the platelets, aspirin breaks the first link in this tragic chain. It is critical to distinguish here between cardiac arrest versus heart attack. A heart attack is a plumbing problem, whereas cardiac arrest is an electrical problem where the heart system malfunctions. A severe heart attack can lead to cardiac arrest, but they are not the same thing. Now, we must talk about the third aspect and the dark side of this pill, the side effects. This is why aspirin is not a harmless candy. If the FDA were to review aspirin today, it would very likely become a prescription drug. The reason stems from the risk of causing allergic reactions, stomach ulcers, and especially gastrointestinal bleeding. But the most serious side effect, the main factor that caused the U.S. Preventive Services Task Force to change its recommendation, is the risk of bleeding not only in the gut but also in the brain. This is where the risk-benefit balance comes into play. The old recommendation was often based on age, but my perspective has always been different. The use of aspirin must be based on evidence of disease, not age. Only when you truly have plaque in your arteries should you consider aspirin. What's interesting is that the new USPSTF recommendation has moved much closer to this philosophy. This change stems from a core concept in medicine, the difference between primary prevention and secondary prevention. To put it simply, primary prevention is the effort to prevent a first heart attack in a healthy person. Meanwhile, secondary prevention is the effort to prevent a subsequent heart attack in a person who has already been diagnosed with plaque or has experienced a cardiovascular event. Applying aspirin to the primary prevention group offers little benefit but carries a significant risk of bleeding. Conversely, for the secondary prevention group, who are at a very high risk of recurrence, the benefit of aspirin in preventing another catastrophe often far outweighs the risk. In essence, the major shift from the USPSTF was that they moved the focus of the aspirin recommendation from a broad primary prevention strategy to a more stringent and targeted secondary prevention strategy. Why did this change in recommendation cause so much confusion? The problem lies in the media's misinterpretation. Even intelligent medical reporters failed to grasp the subtle distinction between primary and secondary prevention. They ran headlines like, "Experts no longer recommend aspirin for cardiovascular disease prevention," which is only half true. The truth is, they no longer recommend it broadly for primary prevention, but it remains an extremely important and strongly recommended tool for secondary prevention. Here is a critical point to ponder. By the age of 60, most of us already have a certain amount of plaque in our arteries. This means that many people who actually belong in the secondary prevention group are unaware of it. This confusion has led many high-risk individuals to stop taking aspirin on their own, putting themselves in a dangerous situation. So let's be very specific. When should you take aspirin? The clearest example is when you are experiencing the symptoms of a heart attack. If you feel severe chest pain and the pain radiates to your arm, shoulder, or jaw, those could be the early warning signs of a heart attack. In that emergency situation, the two things to do are to call for an ambulance immediately and to chew 1 adult dose aspirin 160 to 320 mL. This action has been proven to save many lives. The baby aspirin dose is typically 81 mg, used for long-term prevention, while the adult dose is used in emergencies. To better understand secondary prevention, you need to know that it applies to anyone with evidence of plaque. This plaque can be in the coronary arteries that feed the heart, the carotid arteries in the neck, or even the arteries in the legs. You don't have to wait until you have a 50% blockage or clear symptoms. Early detection of plaque is the key. I have mentioned the term plaque several times. To truly understand what causes a heart attack, we must understand its nature. Most people imagine plaque as a hard, dry layer of wax or fat lining the artery walls. This notion is completely wrong. Dangerous plaque is not a solid mass. On the contrary, it is a soft, goopy mass, like an abscess filled with pus and inflammatory cells. This unstable mucus is the real threat. When its thin cap ruptures, the body responds by forming a blood clot at that site. When the clot is large enough to completely block blood flow to the heart, that is when you experience what a heart attack feels like: a sudden and intense crushing chest pain. And here is the scariest truth that many people don't know. You don't need to have a 50% or 70% arterial blockage to be at risk. In fact, studies from prestigious centers have shown that about 2/3 of all heart attacks occur in people with less than 50% blockage. The soft, unstable plaque, though small, is the most fragile and dangerous type. This leads us to a major problem in modern medicine. Why does the most common method for risk screening, the stress test, so often fail to prevent a heart attack? The answer is simple. A stress test can only detect a problem when your artery is already severely blocked over 50 to 70%. It is completely powerless against the smaller yet more dangerous plaques. It misses the majority of people who are truly at risk, creating a false sense of security until it's too late. So you might be wondering, if we don't use a stress test, what should we do to know our real risk? This is an excellent question, and I will answer it with my own story. A journey that shows how to prevent heart attack proactively. Many years ago, when I was in my 50s, I was an endurance athlete and always confident that I had perfect cardiovascular health. I was looking for a non-invasive, inexpensive method that could tell me one thing with precision: whether or not I had soft plaque, the most dangerous kind. That method is called a CIMT, Carotid Intima Media Thickness Test. I went into the test with absolute confidence that I would pass with flying colors. But the result was a huge shock: I had plaque. For me, this was the early warning signs of a heart attack in its most latent and primitive form. It wasn't chest pain, it wasn't shortness of breath, but it was clear physical evidence that the disease process had silently begun in my body. Despite having no symptoms, I was carrying the latent risk of a future heart attack. I immediately started taking a baby aspirin and reevaluated my entire lifestyle. Not long after, I also discovered I had prediabetes, one of the main drivers that promotes inflammation and plaque formation. This story shows the importance of early detection. Aspirin is a life-saving tool, but it is only effective when you know you truly need it. However, there are also cases where aspirin becomes useless, even dangerous. And that is our next topic. As promised, this is the most important part of this warning: the situation in which using aspirin is not only futile, but can also provide a deadly false sense of security. We are talking about atrial fibrillation, AFib. First of all, what is atrial fibrillation? Imagine the atria, the two upper chambers of the heart. Instead of contracting rhythmically to pump blood, they begin to quiver chaotically and uncontrollably. Your heart loses its normal rhythm. Why is this quivering one of the leading causes of stroke? Because when the atria do not contract effectively, blood becomes stagnant, creating the ideal conditions for very large blood clots to form. These clots can then be pumped up to the brain, blocking a blood vessel and causing a stroke. Many strokes that were previously considered of unknown origin are now known to be caused by silent AFib. And here is the harsh truth that everyone needs to know: aspirin taken, which is very effective against the small clots formed from plaque to prevent from heart attack, is nearly powerless against these large and fundamentally different clots. This is where the difference between a heart attack versus stroke becomes critically important. The clot formation mechanisms in these two situations are completely different, so the weapons to fight them must also be different. So remember this. If you have atrial fibrillation, using aspirin for stroke prevention is like bringing a paper umbrella into a hurricane. You need a much more powerful solution, a completely different type of prescription anticoagulant, which we will discuss right now. So, if aspirin isn't the answer for stroke prevention in patients with atrial fibrillation, what is? The answer lies in a class of prescription drugs called novel oral anticoagulants, or NOACs. Familiar names in this group include Xarelto and Eliquis. Unlike aspirin, which only affects platelets, these drugs directly interfere with the body's clotting cascade, offering far superior protective efficacy in preventing the large clots caused by atrial fibrillation. And once again, I have a personal story to share. About 5 years after I started taking aspirin due to the discovery of plaque, I began to feel abnormal heart palpitations. I decided to use an at-home heart rhythm monitoring device. One night, I woke up with the sensation that a fish was flopping around in my chest. I checked my pulse. It was very fast and completely irregular. The device confirmed what I suspected. I had paroxysmal atrial fibrillation, the type of AFib that comes and goes. This discovery completely changed my prevention strategy. I knew that even though I was taking aspirin to address the plaque issue and prevent of heart attack, it would not be enough to protect me from the risk of stroke caused by atrial fibrillation. I had to add a new generation anticoagulant to my treatment regimen. My story is a clear testament a person might need both types of medication for two completely different problems. Relying on aspirin alone can be a grave mistake. It is crucial to understand what is the causes of heart attack for you and what is the source of your stroke risk. They may not come from the same source. Now let's talk about a topic that many people are interested in: natural alternatives. Can supplements like fish oil, garlic, ginger, turmeric, or nattokinase replace aspirin or other anticoagulant drugs? It is true that these supplements have mild anti-inflammatory and blood-thinning properties. For example, omega-3 fish oil can reduce the stickiness of platelet membranes. They have certain health benefits and can be part of a healthy lifestyle. I use them as well. However, and this is a truth that many may not want to hear, natural methods cannot replace and are not powerful enough to provide protection equivalent to prescription medication in high-risk situations. Heart attack prevention. When you already have plaque or stroke, prevention, when you have atrial fibrillation, is a truly serious battle. You cannot bring a dinner knife to a battlefield. Relying entirely on supplements in these cases is a gamble that I would never encourage my patients to take. Finally, I want to reiterate this: while aspirin, NOACs, and supplements have their roles, nothing is more important than lifestyle. Managing your weight, controlling your blood sugar to avoid prediabetes, and a healthy diet remain the most solid foundation. How can we prevent heart attack most effectively? It is the intelligent combination of lifestyle, understanding your personal risk factors like plaque, atrial fibrillation, or LPA, and using the right medical weapon for the right enemy. Never gamble with your health. Do your research, ask your doctor, and make informed decisions based on evidence, not on hearsay. Thank you for your time and attention.